Well, now we're moving into our clinician session. And again, we're so grateful that we have Dr. Mirian here today. I know he was introduced this morning during the clinician session, but I thought, as some people came in during lunch or right before, if you could just take a moment to explain myasthenia gravis in your own words, or actually imagine you have a patient with MG who is recently diagnosed or just diagnosed. How would you take those 2 to 3 minutes to explain MG?
So, autoimmune myasthenia gravis is an autoimmune condition, okay? And it typically causes what I said earlier, a fluctuating or variable painless muscle weakness. In patients with myasthenia gravis, they will typically, a lot of patients, at least initially, may have weakness in what we call an ocular uh, muscles. So they may have a droopy eyelid that goes up and down or fluctuates. They may have double vision that changes in characteristic. Um, and patients with myasthenia then may go on to develop or initially present with non-ocular symptoms, meaning they may have weakness in muscles that are required to speak or articulate appropriately, to chew, to swallow, to keep the head upright, so in kind of neck muscles. And this condition also can affect the arms and legs, and specifically in muscles that what we say is proximal, meaning muscles that are closer to midline. So muscles that are important for keeping your arm up, um, and bringing your leg up. And it typically affects both sides. Because it's an autoimmune condition, this means that your body is unfortunately recognizing a part of your body as foreign, and is the immune system is attacking it, in lack of better words. And so in myasthenia gravis, we have for many patients, but not all, but antibodies that are produced where the muscle's receiving communication from nerve. And so, we have antibodies. AChR is the common antibody, or MuSK. But many patients also do not have antibodies.
Thank you for that. When we did our Canadian myasthenia gravis journey mapping study, individuals did comment that one of their first symptoms was ocular in nature. But they also, as they were reflecting in the interview, had really associated some of those earlier symptoms to stress or a stressful life event. Do you hear that often? Is there evidence behind a stress contributor to myasthenia gravis?
So yes, what typically might happen in a patient's journey, and from what I've seen, is that all different types of stress, whether that's emotional stress, psychological, or there's a medical issue at play, or just very severe fatigue from other factors, has brought out symptoms that ultimately end up being diagnosed as myasthenia gravis. So it's not uncommon for a patient to start to experience more symptoms, or at least their initial symptoms, in those scenarios. And then as many patients experience those symptoms can fluctuate with those scenarios as well. They can feel weaker with maybe after a night of really poor sleep, or so forth. So that is a typical part of the condition.
Another question that I had is during our myasthenia gravis study, I really learned that, we heard about the diagnostic odyssey. We also had learned that individuals sometimes had entered into a myasthenic crisis, were in ICU, and a neurology, whoever was on call that time came in and said, this looks like MG, and was given methadone. But how is MG diagnosed?
Um, yeah, that's a good question. So myasthenia gravis, or autoimmune myasthenia gravis, is really diagnosed with three major components. So you have the symptoms and signs, or the clinical assessment. You have antibody testing that we can do. And then we also have what we call neurophysiology, or diagnostic testing, with something called nerve conduction studies, or EMG. Um, and there's certain components of that we can use to look specifically for a condition like myasthenia gravis. So all those three things are combined to arriving at a diagnosis. Um, so yeah.
I do have a question just because I've heard this last week, which is to say, is antibody testing easy for patients to get or on the reverse for clinicians to order? I'm looking for an advocacy issue here that I might want to act on.
So yeah, that's it is an issue. So not all labs offer antibody testing for myasthenia gravis. As you can imagine, it's a rare condition. Not all labs will offer that testing. Um, and so sometimes it is restricted to certain centers or clinics. So there's an access issue. And then there's also nuances in terms of the type of testing that is done on these antibodies. But yes, it's not universally available at any lab.
So I put up a slide with a couple of photos of the new treatments that have come through, and you spoke about this morning. As a neurologist, what does these new treatments really mean for you? Is it changing your care yet in terms of management of MG? What needs to get there to see a change where I continue to hear from patients they're continuing to be on prednisone, they're might be doing well with that, or mestinon as a thiopine or IVIG or SCIG. And I know they're not all listed on public programs. So what helps us to move there, or what do we need more in terms of data or science? What's the barrier? I would wonder.
It's a barrier for the newer novel therapies. So it's my opinion or my take is that actually a lot of patients, not all, but a lot of patients typically do well on what we call conventional therapy. So this is prednisone or mestinon, azathioprine is something that you brought up. But there's a big side effect profile to some of these medications, especially prednisone. And not many patients respond well or well enough. So there's definitely a space for these newer therapies, and it's been a game changer to have them introduced in the last number of years. And so access is a bit of an issue, but I'm optimistic that will only get better. And also there's criteria to obtain these medications as well, which is another barrier. But I think the space in general is moving in a very positive direction. But there are some gaps, like you mentioned. There's access gaps. There are clinical criteria that need to be met. And not many neurologists may be that familiar with it. So it is a little bit provider dependent and provider dependent in terms of practice patterns too. So when to start to think about these new medications is another area that's not uniform between all practitioners.
Ahead of today, I had asked a few of the participants on what question they would want to ask you around treatments. And one question was, can you explain this new class of therapies, FcRn inhibitors? What is that all about?
So FcRn inhibitors, basically the way they work. So in myasthenia gravis, the main antibody that is being produced is of the type of that's called IgG. Okay, and this medication lowers all IgG levels of antibodies. So it's depleting your body's amount there. It does it by blocking the recycling of this process in the body. But basically, it's bringing all IgG levels down. And by doing so, we'll bring down presumably the antibodies of AChR or MuSK that's being produced. So that's the main mechanism that these FcRn inhibitors have.
And how does that differ from complement inhibitors, that class of drugs?
So in terms of AChR myasthenia gravis, so this is the most common antibody for autoimmune myasthenia gravis. The way that this antibody, when it binds to the receptor, to acetylcholine receptor, the main mechanism that it causes issues is through something called the complement cascade. And this is basically a biological form of destruction of this receptor. So these complement inhibitors is exactly what it sounds like, will prevent that from being initiated. And so these medications, the role or the thought is that if we target the main way that these antibodies work, then should provide symptomatic improvement. But it's targeting that very specific way that most antibodies exert their effect or act on the receptor.
So that actually brings me to my next question, which is what does these treatments work look like? Oftentimes we hear from a reimbursement perspective, it's your score on an MG-ADL, a quality of life measure. And I know many patients, probably individuals in this room, are not in favor of that as being the best assessment. But as a neurologist, how do you look at someone's performance on a treatment or and say, this is good enough? What does that look like?
So how to track someone's progress. Okay. For me specifically, what I do, I use a couple components, but one of them, so one plain and simple is how they're doing in terms of our conversation during their appointments, their exam, comparing that to before. But that now doesn't always capture everything, right? It's an exam at a very brief moment of time. There's been maybe 2 or 3 months that have gone on, and things can change day to day, right? So I collect the MGADL or patient-reported questionnaire at each visit. And then there's other types of scores that I calculate. These are more scores based off either the exam or a combination of the exam and patient-reported symptoms. And so I kind of basically put them all in a table at the bottom of each of my patients' note to get a sense of their trajectory over time, and put that next to medications that they're on, so I get a sense of what how things are evolving from multiple aspects.
We heard about biomarkers earlier this morning. Is that something or other tools that are on the horizon that potentially could help to influence us knowing what's a good response, what's a good enough response, how people are doing on these new treatments?
Yeah, I think we're not there yet overall. So I think in terms of someone's response, we have some of the things that I listed, whether it's a questionnaire or an exam or a combination thereof, and they have different names for those items. But in terms of identifying aspects of a patient, whether genetically or through blood biomarkers, of what treatments could work best from the ones that are available, we're not really there yet where we have that at our disposal to guide treatment in that sense. Nor do we have really a sense of a biomarker or a biological biomarker to say, hey, this is increasing over time. Perhaps we might need to increase one of the available treatments to prevent a possible worsening that is about to happen. The exception of that, I would say, is those individuals with Myasthenia Gravis. We know that the antibody titer, or the amount that is present, can be a little bit predictive of how someone will do in terms of a relapse. But for the more common AChR, Myasthenia Gravis, or seronegative, we don't have anything to guide us in that aspect.
So now switching gears in terms of care, one thing that we had also heard in the journey mapping study is a lot of the healthcare is fragmented. So your family doctor is sort of managing things on your own, and for the most part, you're really told to go to them. And then there's the neurologist, and you might be visiting them every 6 months, every year, and there might be other specialists. What's the value of multidisciplinary care in management of myasthenia? And is it common for there to be multidisciplinary healthcare teams in the management of myasthenia?
Yeah, I would have to say that for the most part, from what I've seen and talking to colleagues, not strictly in Canada, from around the world, that it seems like multidisciplinary care for myasthenia gravis is actually uncommon compared to other neuromuscular conditions. But I think that's an area to improve on. Not all clinics, for instance, have a nurse or a nurse practitioner available as well, or for instance, a physiotherapist or speech language pathologist that may be very familiar with myasthenia. So it is a bit of a fragmented space. Um, and certainly with referrals as well, there's not many may be aware of the condition, and so that um, provides diagnostic delays. But in terms of multidisciplinary clinics, it seems to be a little bit more common in certain countries, but not one that is widespread in Canada, at least.
The most common healthcare professionals that people in this room had shared with me is going to ophthalmologists or ear, nose, and throat or speech swallowing specialists as well. And so they, again, just really want to reinforce it would be nice without having to reshare your story, reshare your clinical case to have that multidisciplinary management. So looking ahead, what areas of MG are you really excited about? I know there's these new treatments, but outside of that, what's really exciting around MG? Or if you can reflect, I heard some reflections earlier today of people as they started out or what they studied versus now. Would love to hear your reflections on the changes.
So what I'm personally very excited about. So excited about different things. So I've more recently become very interested in this biomarker space because I do there's not a lot of, let's say, studies on it. It's a lot newer in terms of myasthenia research, but I am a bit excited about a lot of colleagues that are doing research and trying to understand um, patients with myasthenia in terms of why they may have responded so well to prednisone, whereas why other patients maybe minimally or did not. And I personally think that could be the way of the future of us once we make the diagnosis, having a much more informed idea of the medications that are most likely to work. Outside of that, myasthenia is fascinating. I think there's so much to learn about. Why do certain patients only have weakness in one area versus another? I think it's something to learn about. Does that impact their trajectory? Um, and then there's a couple of other topics that are, I think, require more research is, care for patients that are elderly and have a new diagnosis because we're seeing much more new myasthenia being diagnosed later on in life, and we're not certain why, as well as during pregnancy. We have very little research in terms of what should guide optimal care in that setting too.
What about in terms of outside of treatments? I'm also thinking in terms of digital tools or wearables or in an era of AI. How can that, is there any indications of influencing myasthenia gravis diagnosis or treatment management?
Yeah, I have to admit that's one that I'm not too familiar with. Other techniques for kind of diagnoses beyond what we're doing already, in that something that a patient can buy and then be informed, something like an Apple Watch for rhythm issues. There are techniques that colleagues are using, particularly with eye movements, to get a better sense of patterns of eye movement abnormalities as well as facial weakness, and patterns of that in myasthenia. And so that seems to be an area of research that may become more available to patients down the line, especially if they've not been diagnosed yet. So I think that might be one particular area.
What about the rare forms of myasthenia gravis? And oftentimes these new treatments are for a particular type of MG. Is there some hope or some developments on the horizon for those rare forms of MG?
Well, there's been so the area that I could say that gets the most attention is generalized myasthenia gravis that is antibody positive. So, these clinical trials have they're represented the most or either exclusively. And so there's not much in comparison to patients that are either seronegative or have the MuSK antibody. And so that's kind of an unmet area. Particularly, I would say the patients with seronegative myasthenia gravis, I think, is one because the options are very limited.
When you reflect on the patients you've seen with myasthenia gravis, outside of those, related strictly to their MG, what have been some other issues that you've heard about or that they're stuck on? So, for instance, I had a neurologist just recently reach out and say, MG patient, not within my scope, but really struggling with housing in Toronto. Are there issues like that or that are brought forward to you, or is it related to mental health or well-being that you can see as part of the MG, but you're focused on the disease, but that you've have experience with?
I think one that's common probably to many practitioners that see patients with myasthenia gravis is fatigue. And I think I briefly talked about this in the earlier session. Fatigue is one where, yes, we've developed, let's say, questionnaires for, or there is some research on what lifestyle uh, um, adjustments that can be made to minimize fatigue in patients with myasthenia. But it's one where it's I think it's quite hard for us to know what to do with in general. None of the treatments are geared towards fatigue, for instance. Many patients, many practitioners won't adjust treatments based off fatigue. And there are things that can be associated with fatigue in patients with myasthenia. So it may not be the myasthenia directly, but we know, for instance, I was just talking about this just half an hour ago, that obstructive sleep apnea is more common in patients with myasthenia gravis. So kind of both. It's a bit difficult in terms of knowing how to tailor treatments because we don't really know. I can't say that I do, for instance, to fatigue, as well as exploring other causes of it. And I would say the second biggest issue that I see is that you're immediately providing a lifelong, life-altering diagnosis to someone, and so there's I would think most often a pretty significant psychological impact that I get to see, and 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 some patients need help with that, right? In terms of understanding their disease, but also coping with how it can be different day to day. I think there's a lot to unpack there that sometimes is hard to do.
Even in the absence of these new treatments, how do you as a neurologist approach treatment decisions or when to switch treatments? And I ask this because during our journey mapping, we heard that there might have been aggregate, but lack of shared decision making. So what we mean by that is oftentimes patients felt like they were told, like, this is what you're going to be on, this is what you're prescribed, and this you're switching, but no rationale for it, or didn't really see the reason for it, or probably they were advocating for a change and not yet you're good enough. So how do you approach treatment decision making in your patients in a short clinical visit?
Yeah, it's definitely challenging. So, I like to think I'm pretty pragmatic, and try my best to give the available options that I think that are certainly reasonable or have the most evidence behind that, and what someone would qualify for. And then there's many scenarios, right? For instance, it could be working, but there are intolerable side effects. So, prednisone or steroids are infamous for that. And so that may be a reason to at least add or switch something to minimize steroid use. Um, and 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 the good enough part of your question is challenging, right? It's how do you define that? Maybe that's not captured on the questionnaire, but it has a huge impact on someone's occupation. And that double vision that they're experiencing as, let's say, for instance, a chef is even a little bit is not, is far from ideal. So that really needs to be taken into consideration. And part of that sometimes is advocacy for either escalating or not. But it's a hard it's a hard aspect of care because we want to also safely get to our goal. So that's another consideration that I have to keep in mind too.
I have a few other questions, but I thought maybe I can pause and turn to the audience to see if there are any questions you have.
Yeah.
Hold quite close.
Yes, I will. Hi, doctor. I would like to know the latest in the stem cell therapy with its relation to the autoimmune disease such as Myasthenia Gravis.
Yes. So what I could at least say is that in terms of, so in terms of how we choose therapies, there's different levels of evidence that we can kind of say for a specific medication or therapy. And sometimes it's helpful to refer to what we call guidelines. So what is most widely accepted as practice for treating or managing a condition. And in the international guidelines for myasthenia gravis, at least the latest one, stem cell treatment isn't really part of that, is not part of that. Now, is it ever used on a really exceptional case basis if nothing else seems to be working and things are moving in a very bad direction? Yes, there are circumstances, exceptional circumstances that may be the case. But I think the reality is that we still have a lot of options for myasthenia gravis that work quite well for most patients prior to reaching something as uncommon as stem cell therapy.
What's MG most often confused with?
That's a hard question. I like it. It's good. It's good. It really depends on what someone is initially presenting with, because although we have these kind of typical or characteristic kind of weakness in myasthenia gravis, it sounds like a cliche, but really every patient with myasthenia is very, very is truly different. But in general, if you have ocular symptoms only, many patients will be misdiagnosed with what we call like a cranial nerve palsy. So one of the nerves that is controlling eye movement has been damaged or is weak. That's a common scenario. And then perhaps someone just says, "Oh, I could wonder whether that happened," and it's just gotten better on its own. And then, if you have speech or swallowing difficulties from the onset, many people may be stroke may be one of the main considerations, but ALS is also another thing that could be brought up. And then if it's strictly just neck muscles, there's muscle conditions that could look like that too. So what we call myopathies that could look like that, as well as if it's just strictly affecting the limbs only, muscle conditions as well that can look like that, which there are a variety.
This is probably the hottest question on the internet. After COVID shots or vaccines, have you seen an uptick on MG or other autoimmunes?
Yeah, from a myasthenia perspective, I don't think there's a really clear association with that. But this is brought up. Vaccinations in general are brought up for other autoimmune conditions, even in the neuromuscular space in general. I think the most common one would probably, or the most common one people would wonder about or worry about is Guillain-Barré syndrome. But from a myasthenia standpoint, I really don't think there's a true relationship there, is my take.
Just as you think of your next question, on the topic of vaccinations, some of these new treatments require vaccinations. Can you explain why?
So the complement inhibitors require meningococcal vaccinations prior to starting. So the complement inhibitors really take away one of the main mechanisms for your body to fight certain infections. And one of them is meningococcus, which can cause meningitis or inflammation of the lining of the brain directed to a bacterial infection. So to really minimize the probability of that happening while you're on this therapy, meningococcal vaccinations are mandatory. The pathway to doing that can be a little bit different, but that's mandatory for those type of medications.
So then knowing that there are these treatments that potentially would require such vaccination, do you think in a couple of years it might be routine that at time of diagnosis of myasthenia, you would be recommended to have?
Yeah, so this practice is already being taken up by certain clinics in the US. And their pathway to have someone vaccinated is slightly different, and that might be part of the reason. But definitely, at least in Boston, at certain clinics there, people at diagnosis or at least establishing care in clinic will be advised to receive vaccinations, even if they may not qualify for this medication, just kind of prophylactically in case they do need it. There's no delay. So I do envision that we will probably get there as well, where we're vaccinating patients so that if they do need it, there's not as much of a delay, at least from that standpoint. That's my take, but.
We'll take one last question.
Hi, Dr. Mirian. Does early diagnosis helps for remission? And are there any studies in this way? Thank you.
So there's studies more geared towards what are the factors for someone that has ocular myasthenia gravis more likely to then generalize. So there's more studies on that rather than, how quickly did we get them into remission, for instance, or just with minimal symptoms. In terms of, factors that relate to if you have ocular myasthenia gravis, what may predict you to then generalize? The main one that seems to be consistent is antibody status. So if you're AChR positive, for instance, you're a lot more likely, and that seems to be very consistent in terms of risk factor. My personal take, so I don't think there's a lot of evidence to back this up, but my personal thought is probably it does have an impact on how likely it is that your trajectory will be favorable, at least the earlier you get into what we call minimal symptom expression or remission or minimal manifestations. But is that inherent to what the course would have looked like to begin with? Was it always going to be slightly less turbulent? I don't know. But I do think that maybe if patients are treated slightly more aggressively up front, they're maybe more likely, but I don't know if that's really borne out. I can support that well.
Join me in really thanking Dr. Mirian for answering a broad set of questions. So thank you.